Hi friends, I am Dr. A.S. Prasad from Kanpur, UP, Bharat, India, and today I'll be talking about how to convert a valgus deformed osteoarthritic or arthritic knee into a successful total knee replacement. Why valgus knee? We all know when we do around 100 knees, around maybe 2 or 3 of them have got valgus deformity, and maybe one of them will have a fixed valgus deformity. So today what I'll be doing, I'll be discussing about valgus knees through a small presentation with my narration and followed by a surgery of a valgus deformed knee and how I have converted that to a total knee replacement. So basically it's how I do valgus knees in my setup and this is my style. But the point I want to emphasize, it's not a big deal to do a total knee replacement in a valgus knee. The only thing we have to take care of minute details. And what are those? The concepts do not change. We should go stepwise and keep on verifying whatever we are doing right. Because a single error, if you err on one step, it keeps on magnifying. The subsequent steps are based on that step. We should not forget that. So, friends, that is the issue. And remember, at the end, we must have a very good balanced knee. The balancing is the key. And what is my definition of a balanced knee? When we put up the trials and we take it into the full arc of extension to flexion, my trial should not budge. They should not move. That means the patella should track beautifully in the trochlear groove. If that is the case, yes, our knees are balanced well. If not, we should tweak. We can use saw. We can increase the posterior slope by a couple of degrees to see that. We can always play with our gaps. We can reduce the flexion gap by flexing the femoral component a little, shifting the femoral component a little down. So there's so many ways we can try to balance the gaps, and also we should aim to balance the knee in absolutely all the range of movement. That is the key. So hopefully you will enjoy. So first watch my presentation with my narration and followed by a surgery which I have recorded in May this year. Thank you. Enjoy and let me know in my comment section also. I would love that if you can do that. Hi friends. So in continuation, I'll just show my presentation and hope you'll enjoy. It will have some salient points and then you will watch the surgery which I have recorded. So this is my way. When I say my way, that's how I do it. But yeah, the concepts remain same. You can execute them in your own method, and definitely every patient is different. So everyone will have to tweak something according to the patient you are tackling. So remember that it is just an idea how we can do it. So the number one point is planning. We all know. We must have a plan. Yes, this is the deformity. These are the bone defects. This is the ligamental structure. And this is what we are planning to do. And you must have a backup plan all the time. And backup infrastructure or backup armamentarium also. That's very, very important. Then you start executing your plan on the table, on the patient. So number one was before surgery, number two is during surgery, and number three, I think is very important and more so in this case of valgus deformity, is empower yourself to change plan during execution. That means if any obstacle you encounter, are you equipped to handle that? If you are not, please go and work with your colleagues, your seniors, your friends, and get more exposure. I've got exposure to so many techniques which in my practice I have not done, but I know if need arises, I will be able to do that. So these are the very important things. And let's go to valgus knee. These things hold true for all these surgeries we do. Not these are not specific to the valgus knee. So first is evaluate the deformity. We all know in theory it has been divided into three broad groups. based on valgus angle, flexion contracture recurvatum, and these are very important. Flexion contracture, or if there's a recurvatum, that means you start visualizing. Yes, recurvatum. That means the gap in extension will be more than the flexion gap. So you start where the joint line is. Maybe both the condyles are so eroded, the joint is in lax. So remember, start visualizing why. A flexion contracture, is it inflammatory arthritis? The posterior capsule is contracted as well. The soft tissue structure is contracted as well. So these are the things, standard things. And then range of movement, we all do it, all the knees. Extensor sheath, strength, how the quad is working, patellofemoral articulation, how patella is, skyline view shows what. Is it the patella is subluxating laterally or it is centrally placed? Will give you a lot of idea what you're going to do for your planning and what you're going to plan or execute during surgery. In valgus, the stability of medial collateral and medial opening stretching. This is very, very important to know the integrity of medial side. And neurovascular examination, especially for the lateral popliteal nerve, which should be recorded because sometimes post surgery we find neuropraxia, maybe nerve damage also. So there should be records of that. And then watch, try to get the patient walk, either with support or with a walker. It will give you a lot of idea about his gluteal strength, how he holds his body, his spine. That will give you a lot of insight into how you're going to tackle your patient post-op also. So based on clinical radiological information, we have three broad groups of valgus knee. We all, that's theory. But the first one is simple. There's a mild bony deformity leading to valgus knee, but we don't have much bone loss, we don't have such contracture, and it may correct forcibly when you try to correct it for stress. It might correct to almost normal level of valgus. Normal is 6-degree valgus. It will not go beyond that, but it might correct to the acceptable valgus angle of the limb. And the second group, which I think we encounter in our practice mostly, are the medial structure still intact. The most important, that is sacrosanct thing. Bone loss is there. Soft tissue contracture doesn't allow correction of deformity fully. And these are 10 to 12% of valgus knees. I'm talking about not totally valgus group. So 80 to 85% of valgus knees are simple grade 1. So don't bother, go stepwise, it will be fine. The second is only 10 to 12%. That is what I'm telling as a book shows. And the third one is attenuation or defective medial capsular ligament complex. And this is, my friend, is something we are scared. We have to have a backup plan. The fixation for fixation of the implant to stabilization of the implant. So we may have to use a sleeve, augment, stem. The stem is very common anyway. Or we have to think of constraints. So these are the cases which are very few in number, but will take our most skills are tested in such cases. Remember, these are the toughest valgus knees, and we all tackle. We'll have to tackle. You don't think you will get only one or you will get only grade 2. No. When you start, once you are in the sea, learn to swim, and that is the motto. So you want to see this sorry. Got one side okay. So basically, it is just showing how much deformities are there. This is stage 1 definitely. This is stage 1, and this is stage 2. I don't have a picture of stage 3, but I can show you with so much of bone defect anyway. But most important thing which I want to say, how I do it, and there is one. So you see, this is a valgus knee, and you see how much it is a fixed knee. Absolutely, it is I'm testing it under anesthesia, and it's still the residual 30 degrees of. And you will watch this surgery live, recorded after my presentation. This is the patient I've recorded just to show. I think it's the same. Maybe no, probably not, because this is a presentation was made much before. But most important thing, my way of doing is same, standard, anterior incision and a pure medial parapatellar orthotomy. I have never done a valgus knee from the lateral approach. I have done one knee, a varus knee from the lateral approach, because it was that was the time when I was doing bilateral. So I just to you wanted to please your colleague. I told him, oh, you open from the other knee while I'm just getting a trials done here, so that I'll come and start doing it. And he, unfortunately, because I'm ambidextrous, I work from both the sides, but he was not tuned, and he did a lateral parapatellar orthotomy on a varus knee of the other side. And then I had to stop him, but then already he had done that. So we did a totally replacement in a varus knee from lateral parapatellar orthotomy, and I could do it anyway. So in this valgus knee, my standard approach is same: medial parapatellar orthotomy, and then not going into the central tendon, I'll go into the vastus medialis, and that's all. Like a routine knee I do in every case, this will be same. So no changes, same, and I will evert the patella if it is doable. If not, I will subluxate the patella and then expose the distal femur and tibia. So my approach is same. Whether it's a varus knee or valgus knee, I never had the occasion or was forced to do a lateral approach. No. In toughest knee, I do same. And I never had any issue. And I told you I have done a lateral parapatellar orthotomy in a varus knee. Not in, that's funny also. But anyway, result was good. So the important thing again, the point conceptually. Ultimately, we have to create a gap between tibia and femur to accommodate the implants, and that cut surface of the tibia and femur in extension should be between 19 to 22 millimeter. That will take 9 millimeter of femur and maybe 10 millimeter of tibia to 12 millimeter of tibia, something like that. So nothing more, and that gap will come from tibial cut, distal femur cut, and existing gap. So remember that the existing gap you cannot forget. The existing gap is also when you, yeah, there may or may not be gap, but please remember to create a gap which will take this value also. That's very important to have just in your mind. The things by doing a proximal tibial cut is same. Whatever knee, varus, valgus, flexion, extension, whatever recurvatum, alignment has to be, you have to decide. Posterior slope based on the type of replacement you are going to do. You're doing a cruciate retaining, you'll go to anatomical slope, going to cruciate sacrificing, 3 degrees of slope, which I balance during balancing I'll increase. If it's a rotating platform, you'll go to 0 degree of slope. So that is very important. Depth of the cut will decide the gap we want to create. And remember, the depth is also important. How much bone from which side? So maximum 5 millimeter thick from medial condyle. Why I say medial condyle? Because I'm talking about valgus knee. So the lateral condyle is already eroded, and if you go into the anatomical landmarks, so our knees are loaded in varus. So when we are cutting 8 to 10 millimeter of tibial thickness from healthy lateral condyle, the medial condyle is cut from 0 to 5. So if it is eroded, it may be 0 or maybe there's a gap, but we do not cut the ratio between 8 millimeter and 5 millimeter is what is loading it to the virus. So if when you're cutting 5 millimeter thick bone from healthy medial condyle, that means effectively I'm removing 8 millimeter of bone from a healthy lateral condyle. So that's why I said maximum 5 millimeter thick from medial condyle. Sometimes it is both are eroded, you cut a little less bone, try to see how much the gap is, and we can always leave the pinpoint marking. I do not leave, but you can leave it so that when necessary we can increase the depth of the cut easily. So it is always prudent to, if at all, want to cut bone, cut it later on rather than from the very first beginning. So that's a tip I'm telling you. Then the bone cut from femur, the distal cut decides the alignment and extension gap. So alignment we go valgus angle how much, and the depth of the cut. Depth of the cut will depend on the surface of the distal femur condyle. If both are eroded, you are not going to cut 9 millimeter. We will assume, because if you cut 9 millimeter and the surface is eroded, then you are going back into the eroded surface. The joint line will lie at the eroded surface of the femoral condyle. So we have to restore the joint line. That means restoration of the joint line is the most essential for an adequate and good function and good stability. So try to remember, you may have to cut this not 9 millimeter. That means less than the total thickness of the implant we are going to put. The posterior cut and anterior cut decide the femoral component rotation. So that's again, we can, if posterior condyles are eroded, we can have a good surface of the tibia, cut surface, which will give us how to make a parallel cut there. And that's why I said, in valgus, the eroded surface of the femoral condyle will not give you a guide into 3-degree or 5-degree rotation. The cut surface of the tibia, which has been verified that it is cut well, becomes a good landmark to create a rectangular flexion gap. Rest chamfer cuts are to adjust the internal geometry of the implant. So don't bother about them. These are important, vital cuts which will help us in stabilizing the implants. The distal valgus angle is again very, very important. If you look into the literature, Dr. Chitranjan Ranawat talks about 3 degrees of cut irrespective of whatever the deformity is in valgus, definitely. So he has a point that he has based it on the distal metaphyseal bowing of the femur. And if you look into the original paper on the valgus knee, because he has talked a lot on valgus knee, and the recent paper which Amar Ranawat is also there, both talk about 3 degrees of valgus angle. However, you can take 4 degrees, 5 degrees anyway normal. But I use computer navigation, so I remember in the valgus knee, my computer was telling me 5 degrees. I kept on thinking, but then I said, no, okay, computer doesn't know this femur has a metaphyseal bowing. It's evaluating with the center of the hip and center of the knee. But so I can cut it. I tried. But whether it's 4 degree or 5 degree, I don't bother. I have to cut it right angle. That's all. So sometimes it is there. So I think in my experience, I'll say between 3.4 degrees is good enough. Don't try to cut less than 3 degrees of valgus, because then you might have little problem in having the balancing the tissues also. Some people have started now cutting the tibia and little varus and matching it on the femur side so that there's a less strain on the medial soft tissue structures also. But I have never tried, but my friends have been talking about it and they say it looks good, it becomes very comfortable. The medial collateral is less strained now. But anyway, let's see. So distal cut I've already talked about, so I'll not go into detail, but if both condyles are one, it's prudent to cut 7 millimeter instead of 9 millimeter. And these are the condyle where you will get hyperextension or genuine recurvatum. Undersized femur may be needed to increase the flexion gap to accommodate the thick extension gap, thick poly or in extension. So remember this. In genuine recurvatum, that is very important. Undersize the femur so that your flexion gap is more and becomes equal to the extension gap, which is already increased. So there are so many tricks we can do. And remember, the bone may not be cut from the distal femur, absolutely on the lateral side. Don't bother. I have got patients where no bone was cut from the distal femur. Ultimately, I had to just take a sliver of the bone and make a drill hole, and we had a thick cement there. So that will work. So don't worry. External rotation I have already talked about, so nothing great here. But remember, your bony landmarks may not work in all the time. So your cut tibia surface, if it is cut well, it becomes the best landmark to know how rectangle gap is going to make in the flexion. So that's why I said every step when we cut, we keep on verifying it, going all right. But ultimately, your trial is the best. You see, bone cuts are sacrosanct. You cannot play with them. But while traveling, we have to play with the soft tissue. So bone cuts we have done. Some bone cuts like adjusting the slope I can do while traveling. I'll just go into those also. And this is the most important thing. Laminar spreaders are the very important tool in our armamentarium. Complete the cuts, go posteriorly, release the posterior capsule. If it's flexion deformity, we must take out the posterior capsule from posterior side of the femur. Remove all the osteophytes. It will lead to relaxation into the extension gap. A tight extension gap will become now adequate. So remember this. That's why I said I don't try to balance beforehand. Now, once I have done this, I have taken out the posterior osteophyte. If it is a flexion deformity, I'll do some releases on the posterior side, and then I'll see trial and then see how it is on the lateral side. And then these are the points where we can palpate and do a release on the lateral side in the valgus. Take a pressure in the full extension side, try to go lateral, palpate what are the tight tissue, and then we can release it. This is the trick, just showing the, and we can pie crust or cut small give cuts also at the surface of the joint. And so we have done everything, and then we do a trial, and you see, I'm looking at it, it's tight in, it's going into valgus also, and it's not getting full extension also. So we have to see that means soft tissue contractures are there. So what I'll do, that's very important. I will assess it, looks balancing, but it doesn't look nice if you go as you have seen the first X-ray. So what I'll do go expose the tibia, go all around tibia, all around, remove all the fibrous tissue there, expose the posterior lateral corner of the tibia again. I could have done it at one go. I wanted to demonstrate this, so I've done this like this way, because these small things will matter. Remove all the extra bone, the margin, and remove all the fibrous tissue. That is one. And then we can always increase the slope of the tibial lateral wall so that you try and get a good flexion gap or flexion stabilizer, the tibia can stabilize it. But remove all the osteophytes. Even the medial osteophytes, I know the bowstrings the medial collateral ligament, but in the lateral side, the soft tissue structures which are fibrous, they will become, they can be tackled by this, and then we'll see how much tight tissue is there, and then in extension, use a spreader and get that tight tissue released. Yeah, I'm using I use both hands, so it's easy for me to keep on palpating from one hand and use the knife from the other side. And my colleague is, instead of spreader, my colleague is pulling it up from holding the angle. And I'll know the moment I release the tight tissue, it will pop off and become so good. So this is the maximum release we have been encountering, and this 99% of the time it works very well. In couple of cases, I had to do a popliteal tendon cut also. Sometimes I've tried to lengthen it. I do not know how much it works, but it did not. So a couple of cases I had to do a popliteal tendon release also. But now it looks good. And this is the X-ray which, this is another one. The surgery which I'll be showing is different, definite, the other one. So this is another one, which is the X-ray, and now it has been done, which you saw the slides. And this is the no constraint, nothing, simple knee has been done. And this is another one where I had to use a constraint as well as stem, because the moment I use the constraint, I want to do a strain. So this is another case, but and ultimately the other one, you see, I have used constraint, and one I have used the stem, the other one not. But we have to keep stems, augments, constraints, and be prepared for bone graft and the screw and plate. The screw and plate again, a funny story. Not funny so much. Uh, just got carried away. My implant was not going. It just short of hardly 4 millimeter or 2 millimeter. I tried thumping it, did not. I thought, oh well, let me do a trial, and when I will do extend, it will be pushed. When I tried, the femorocondyle broke. It broke, and then I had to fix it up again, and a lot of explanation to my patient. Anyway, that patient is doing very well now, so I'm happy now. But yeah, small error. I could have just redone the cuts, and it could have been, or maybe rasped a little. So no shortcuts are there, friends. Remember that. What else you must be prepared for? Lateral retroculator release can happen to many patients where the patella has to be brought back. The popliteus tendon release, which I have done, the proximal one. Biceps tendon release, I have done only one. In very start of my career, and I burned my finger. It was a very tough case, though, but developed foot drop, and it's more than 20 years, still has foot drop. He walks with a carbon fiber splint. But anyway, I think he's good with me because still his relatives I keep on operating even now. But only one biceps tendon release. But in that case, I was forced to do a biceps tendon release. The lateral collateral release proximal, I showed you that keeps on happening. But the lateral epicondylar osteotomy, I'm capable of doing it. I've never needed to do it. Capable of doing it, I've seen, I've worked with the person who was doing it. I've assisted a couple of them. I've seen the papers, but fortunately, I have never done. Medial epicondylar osteotomy in refixation proximally, only seen the paper and discussed in the conferences. I have never done. This is my first case. Uh, Still, because you see, I started doing knees in 90s, and I still you'll be surprised to know. Recently, one of my patients, whose knee was done in 93, one knee was done 93, 94, and the other was done in 94. landed with a periprosthetic fracture. So that time I was not able to keep all the records. In fact, my record keeping started after 2001. So before that, my records are sketchy, like photographs or something. After 2001, I'm keeping all my patient records. So this 99. So you can imagine I was operating for almost 8 years, and still this is my first valgus knee that time. And that lady, when I'm telling you, she's I think 1994, has broken distal femur. I've kept in a long knee brace, evaluating her for doing a hinge now with a DFR. So that's a big surgery. Whether she'll magically competent to get it done, I do not know. I've already operated her one of the hips also, both the knees, one hip and one shoulder. So it's all metal there. A big Punjabi lady, and I'm now scared of operating for a DFR in 93, 94, but I don't think we have any other option. Probably I'll go ahead and do it. So, as this is the case which you will see now, the surgery which I have recorded. On one side it's a valgus knee, the other side is varus with a lot of loose bodies posteriorly. I'll be showing only the valgus one. But one thing important, before going for surgery, in one of the planning, I take X-ray stretching view, extension. So you can see I have asked my junior to my staff to get a traction view also. We take stress view, but take a traction view, and this also gives a lot of information about the bone depth, integrity of the soft tissue, how they are placed, and how alignment can come. So this is one of the traction views. Stress view definitely we take. And this is the post-op X-ray of the same patient. You can appreciate it has come out very well. No constraint, simple attuned knee, posteriorly stabilized. That's it. So friends, now hope you enjoy the surgery which I have recorded to complete the series of introduction of valgus knee, a small presentation, and now you'll watch surgery. Happy viewing, friends. See you. Bye from Dr. S. Prashant. And give your comments. You can join my YouTube channel. You can watch my mandolin music also, and also the other things there. So, see you, friends. Hi, friends. Again, Dr. A.S. Prasad from Kanpur. Another valgus knee. We get a lot of them, but yeah, I just want to show the valgus angle. This is the valgus angle. Correction is almost 5 degrees only. So after correction also it's 30, almost 30 degrees or maybe more. Flexion is good. We have done tunicate, so I'll just show how I do it. Give me knife. This is tibia tuberosity. I'll just make a straight incision, just medial to the tibia tuberosity. Going from down, like that. So nothing will change. Everything will be same. And maybe we can coordinate the vessels. I can do it like this also. It will be just easy to show the surgery. So in this position, I don't use a smash, so I can see the bleeding points and coagulate them. I can use small clips also, but I think I will go for the demonstration of full surgery. You can see a lot of vessels are there, small veins, and now just coagulate them. Okay, so now I can palpate my patella. Same type of medial parapatellar or shortening, going down, going up, and I'll make a nick into the vastus medialis, which is almost to it, and then extract it.
cut into the medial meniscus and then lifting up the soft tissue from the medial condyle upper part so that a soft tissue sleeve is formed inside which I'll do the surgery. So same, I know the medial, it's the valgus knee, so medial part will be stressed, so I'm keeping the part of the medial meniscus here to strengthen or reinforce the medial part of the or medial soft tissue sleeve. Everything remains same. Finding gap in patellum, removing the pad of fat there and the fibrous tissue so I can mobilize my patella also. And then we'll try to avoid the patella now and stretch the knee. So nothing extra, everything is happening as we do in any case. Punch. Just a little release to see the borders of patella. I don't intend to do any patella button here, but I'll just do a simple patelloplasty. Take out all the osteophyte here. And it simply works very well. I had been doing patella button when it started. So up to, I think from 93 to almost 2001, I was changing patella button in every cases. And then like in couple of cases I burned my finger. Then I realized it cannot be done in all the cases. We have to appreciate the quality of bone. We have to appreciate the thickness of the bone. Then I have got around 25 cases where on one part I have done patella button, the other part I have not done. And then I realized it doesn't make much difference. Even the stair climbing ability was same or similar in both the type of knee. Then I withdrew. Now I am doing patella button in revision cases, but again I'm not now reviewing. I'll see how patella tracks, how the cartilage surface is, and especially in rheumatoid when nothing is left, still I leave. I can't do a patella button in rheumatoid with so much of osteoporotic bone. But they are doing very fine. So now once it has been done, I'll try to anterior subluxate the tibia, and we have got some part of the ACL. I'll not call the proper ACL, but some parts are there. I'll just take it out. This helps clearance of the joint. So basically what I'm doing is can be called joint clearance, and you can appreciate so much of bone loss on the lateral condyle of the femur, whereas the medial condyle looks good. Movement goes little lateral, and patella can be simply subluxated also. So this is what I'm trying to do. Let's see if it works well. Just clearing little more fat from the patellar ligament. We have to be very clear that we don't do any hanky-panky with the ligamentum patelli. trying to clear up the border of the lateral condyle and taking over the lateral meniscus. Hold it. I'm keeping a little part of the medial meniscus here. The posterior horn of the medial meniscus I'm going to remove, but the medial part I will keep there. And later on, if as the need may be, I might trim a little part of the medial meniscus there. But that really works well in strengthening the medial part of the joint, or soft tissue sleeve of the joint. And we already know in valgus knee the medial part is stretched, so it's always a good step. I've been taught by many when I was learning, and I have still kept practicing the same principles. Quite slippery there. Okay, so now we have got a full lateral surface identity. There's a big defect here. Just take out some enterostomic so I can keep my jig here and give me some water. Removing all the fibrous tissue at the border always helps in identifying and also in the dissection. So now we can appreciate there's a big defect on the lateral side, a kissing lesion on the femoral side, and because of this defect, naturally the mechanical tendency will be to go into valgus. Let's cut tibia. I'll be doing a pure 90-degree cut with 3 to 5 degrees of slope for cruciate sacrificing knee. There are so many doctors or so many our friends who are talking about doing a little varus cut now. Yeah. So this jig is centered little lateral to the your spine, tibial spine, little lateral, and the same axis, so that the slope goes and bang anteroposterior. Now I will keep it center the distal part over the proximal crest, tibial crest just proximal to the ankle joint, and that is palpable always. So this is, I'll not try to, it has to be bang 90 degree, maybe little varus, 1 degree is acceptable now, because then again it offloads the medial part. Friends, we have got outliers, we have to work between them, but the crux will be to balance our knees excellent. There should not be any mischief in balancing or any adjustment. So we have got cut and we have got little defect left there. Let me see what, definitely it's zero, less than 0 from the lateral side, but let's see how much we are cutting from the medial side. Medial side is almost 5. So 5 to even 6 is good. And now I'll resect only 5 millimeter from the medial condyle. The medial condyle is healthy. So it's the thickness. And we must remember, if we cut 5 millimeter from the healthy medial condyle, in actual the lateral condyle will be cutting 8 millimeter from the healthy surface of the lateral condyle, because our knees are naturally loaded in varus. So that's important. So this zero is practically we are cutting from a healthy lateral condyle around 8 millimeters of bone. And that looks good. Just finishing again from the slope is adjusted. We can always do a freehand slope adjustment later on while we balance the knee. So it's practically between 3 to 4 degrees of slope. I can check it. I'll be checking it again and showing it. Give me both of them. Six, two, four, there are. Size 4. So again, you see the sizing is taken from the lateral surface. It's small. So this is size 3 attune. I'll be taking size 4 attune. And we'll check. Yeah, 4 from the lateral side looks good. And this is size 4 and it is banked on the tibial crest. So I'm happy with my cut. And this is the first cut has to be important because this cut will decide the femoral component rotation also. So I'm happy with the tibia. Let's go to femur. We have got little defects here, but that will be filled by drilling and bone cement. Hardly 2 or 3 millimeter of defect. That's a contained defect as well. Making a hole. To make a hole, it's better to palpate the femur with the 2 fingers, and then you can see the line and see where the axis is coming. So these two, between 2 reference points, we can try to make a hole, and then go little rotation so that I can see where my drill is going. Now, the another part is suction. This is very vital so that when we push the rod, we do not increase the intramedullary pressure. Again, very, very important. 9.3. 9 millimeter because this is a healthy condyle. Perfect. So we're cutting 9 millimeter from this so that we can restore the joint surface, the joint line. And that's very important. The valgus angle I'm choosing 3 because we have seen how much tight, and if you look at the X-ray, so much of metaphyseal bowing is there. And so this will be a good cut, I hope. So we are cutting 9 millimeter of bone from the healthy medial condyle and 3 degree of valgus. So we may not be cutting any bone from this bony part of the lateral femoral condyle. Let's see how much we are cutting. Protecting the MCL is always vital, whether it's valgus knee or varus knee. This is very important. Another foramen here so that you can see, and one plate which will protect the tibial surface. This cut or this cut, you can always interchange whether you can do distal femur cut or proximal tibia cut. It can be done interchange. You can do either one of first or one. Okay, fine. Let's drop it, otherwise I wouldn't. We are not cutting anything here, but again I will just, because of the sclerosis, there's so much of elevation. I'll do a freehand cut later on. Pin there. Pin. And even in a valgus knee, you see the medial osteophytes are there, including osteophytes abutting the MCL. So I'll remove them anyway. The osteophytes have to be removed from all the angles, and then we will appreciate a lot of osteophytes here. The osteophyte will grow, and it will grow over the soft tissue, including the epicondyle. So here I might have to use a osteotome. I can appreciate the osteophyte here, and you can see the real line is there. The rest everything is osteophyte. So I'll make you take the help of an osteotome or drill and remove this osteophyte. So, now you can appreciate the collateral. This is the epicondyle, and we have not done anything to the collateral. So we have got this, and now I'll just check how the alignment looks like. Fine. Good. Yeah. So it looks good. Still, I think it's in valgus. We can make a little more valgus. So, and in fact, the tibia is also in little valgus. We can check at this time the alignment. Give me the rod. Normally, I will use computer. I use computer navigation. So in this case, I just want to see how we are doing, and we can. I just want to show how I can adjust some freehand. So it is going. If it is going inside, that means this hip is loaded in valgus. Is it?
Yes.
So we'll adjust a little. Some of the adjustments will come from the tibia and some from the femur. Moment. So I think this, because of its process, we have little loaded in valgus. So that's. The surgeon, I do a lot of freehand adjustment, but the concept remains same. So we can always are in making the judgment. Again, I'll check again. I hope we are not going no. I think we are still in little valgus now. So I'll just go a little more here. So, now it's better, much better. But still, I can go a little. Give me thought. This is my computer. This rod is my computer. So that gave me some idea. Right. And then wherever it doesn't, the plate should not rock. That also I'll just check. Well, I can do it good. So now it looks good. So I'm happy. Now let's see with this spacer how if there otherwise I'll adjust a little more on the femur side as well. Yeah. I hope it looks good. Now again we'll check with the rod. It's coming here, good. It's better?
Yes, sir.
अंगूठा हटाओ.
Yes, sir.
Just हाँ यहाँ रखो. अभी भी थोड़ा सा
Yes, sir.
still in valgus. So now I'll adjust from the femur. So I'll get this alignment perfect. Then I'll go ahead and do soft.
Moment.
I'll let go of the jig. Moment. एक और होना. Just with this, I'll see if there's any unevenness. Yeah, this is uneven, and this is so. This because of the scrolls bone, it often happens. So I'll just check with this, and I'll go and just make it even like this. Yeah, now it looks good. Let me check with the jig again. Yeah, now it's good. Absolutely perfect. So I don't believe in putting up again the pins and doing that. Surgeon's hand should be such the control that you can do whatever you want. So again, full one. I'm sorry. Some people may say don't teach the wrong thing, but I think for surgeons, every surgeon balances like this, and you have to give the outcome or good result. That's important. Yeah, perfect. So now it's perfect. I'm happy, so I'll go ahead now. Now I'll do further and do the other cuts and plan the balancing. Nothing I'll balance now. I'll just do all the cuts and then I'll see how my knee balance. And my balancing is always done with the trials. If I'm doing everything fine, everything should fall back into place. And that's what I believe, and I've been practicing, and I've never regretted that. Yeah. So the pins are placed little between 3 and 4. So we have, I'll see what joint I will use. So there's 4. So let's see, because we have got narrow also. So 4 narrow probably will work. And let's see, give me 3. Three is good otherwise. So I can go with a 4 narrow also. This is what I will have. Yes. Yeah, 4 narrow should work. And then we see how much the gap we have. Approximately 5. We tested with 5, that means 9 millimeter of insert. Now again test with the 5. Full. So this is the 5 and we'll see rectangle, it is rectangle or not. At 90 degrees it is rectangle. It's opening middle, lateral barabar. It's equal on opening on both sides. And then how much? We can try 6 also. Let me see 6.
6.
You know. And we always see how much we can go down. Yeah, do we have place? Yes. It's just, I don't think we have place here. So we'll try 6 and 6. Full. Yeah, I think 6 will come. 6 is more solid rock. It doesn't open any side and it is rectangle. So we'll go ahead. We're happy. If it would not have a rectangle, we can easily take in one of the pins and rotate it into a couple of degrees to get a pure rectangular gap. So this was again playing with the jigs, and we can easily do. Taking care that you don't notch entirely, taking care that you don't take off the MCL. So now again we'll check. Give me a moment. How close we are with the MCL? We are we are way down, so no issues here. By changing it, we can go to the very close to the MCL origin or epicondyle. So the couple of things we must take care. I'll just take off the entire plan. So we don't have much place here, so we cannot go down. Still, I had a option. Suppose we were little high. I could have gone down by 1 millimeter, reduced the flexion gap, made it more stable. So it's good, acceptable. I'm happy. Now I'll keep all the other pins. So you can always play with your jig because you know the concept. Concept is to make a rectangular gap. And before that you must ensure your TBI is cut in a proper way because this rectangle gap will be done to the cut tibial surface. And I'll show you, even in valgus knee, the medial condyle is cut more. That means if the condyles are okay, the femur has been rotated. If we cannot reference from the posterior femur condyle, then I'll keep a spacer over the tibial cut surface and decide where I'm going to cut the posterior part of the femur condyle. So that that's exactly true gap balancing. Here we are doing everything, all the mix, and most of the surgeons mix all that. This is the thickness of the lateral posterior condyle, and this is the thickness of the medial posterior condyle. So definitely much more. Give me. So let's see 4. Yeah, still I can check. If I need, we can easily go from this stage from 4 to 3. So I'll just confirm whether I'm okay with this. The inner side decide here, it's here okay, and here it's okay. So yeah. So the 4 narrow we can use. At this point, my junior and I both ensure that it doesn't shift. Even if it shifts, we can check. There are so many techniques to change it. So when I'm 100% sure, I'll go remove this piece of bone from the notch. Once I have done a trialing, then I'll see where the tight tissues are and then selectively release so that my joint gets a good balance. And this is what I'm doing. We're doing a live in a way, recording it. Probably I'll use this video in my forthcoming UP orthoplasty course, which is on November 22nd or 23. And now, give me bone nibbler. Just little thing. Removing all the extra bones, which should not be there. And then I think this is the most vital instrument, and every knee surgeon must have this. Normally, we all have now, but it was one of the best instruments to get my patient the best functional outcome. So now we will release whatever extra bone we have. Yeah, so there is bone. We'll palpate here. Going back and removing, we can see a white line of the border of the condyle. Anything beyond that is osteophoid, and I'm going to remove that. And then I'll just release a little of posteo capsule, and this definitely will give my patients a beautiful flexion. They can sit cross-legged easily, and all my patients sit like this. Definitely, if they have to have pre-op foot movement also. It's okay, Vishal? Two of my colleagues, Dr. Vishal Agrawal and Dr. Adit Narula, are here. And all my team is standard. Dr. Amit Verma is not here today, not keeping well. He'll come. He usually joins whenever he's good days and bad days. On good days, he'll be here. On bad days, we miss him. So that not just rasping, just helps always. And the bones are not very good. So the lady in question has some osteoporosis. Let me look at the lateral side. Doesn't have any osteophyte at all. Again, it's a valgus, but we could get osteophyte from the posterior side only from medial side. So this is very funny. The anatomy is definitely individual, person to person. And you saw that I'm trying to get everything not by the jig, by the concept. Yeah, the axis, the alignment should be good. The jigs are meant to get that achieve that alignment. If I'm not happy, I'm a surgeon, I can use my freehand jugglery skills on saw and get a good alignment. Fine. Give me a trial. After this rasping we could get. Give me a start with 5. Artery forces. 5. So now let's see what we have achieved without doing any releases anywhere, only working with soft tissue. And let's see, little lateral tilting which is usual in valgus knee. Little tight, so we'll have to do some more. It's tight in flexion, it is tight in extension also. So we'll have to do a little release more. So this is what we'll do. Otherwise it is stable, so I don't need it to do anything anywhere. It's stable, it is stable, it is stable, stable. So now we need a little tweaking on the tibia side because it's tight on flexion extension both. So I'll just do a little freehand and we'll show you the balance. I'll again check whether only tibia. Give me tibia. Are we done or we still in valgus in tibia? Because when I'm using it, so I'll just take a rod. This is very important. Yeah, so we are still little. It's okay. It's almost normal. Okay, fine. Yeah, that's true. I would have cut 2 millimeter more that time. But let me see with the rod again. I'll check. So I've done with the femur after rasping because of Spro's bone, and I'll just see it. No, it's still valgus. Give me a little some more. Yeah, give me 5. So now 5 should adjust well. Yeah, the flexion is going well. So the feel good factor has to be there. I'll see. Yeah, it looks good now. Yeah, the feeling is good, and now it's the yeah. So we have, in fact, this much I will not do a proper release yet, but definitely I'll do some patella release. But if you look at the balancing, flexion, no, absolutely fine, and absolutely good access. So we are done now. Little release here that I'm going to do, and because it's so much left, I'll just do a little release after checking where exactly the tight tissues are. So it's almost here. So I'll just do it little release here. So Amit is excellent in doing this. Yeah. So now it's good. Now it's good. So done. We'll go and do the cementing. So valgus knee we have converted to a proper, well-balanced, normal total knee replacement without doing a single release from whether on the lateral side or on the medial side. And that is what I always say. It is a soft tissue surgery, but that means we have to preserve the soft tissue, not release them. Don't try to go for unnecessary release. Only in 2 to 3 cases out of 100 knees you might have or we might have to do release. Thank you for watching. Next is cementing.